Hello, everybody. This is Sadie. I'm the Chief Scientific Officer at the Solve ME CFS initiative, and I'm delighted to welcome you to our 2018 webinar series. Today, we're featuring Professor Leonard Jason, and he's going to talk about appropriately and accurately assessing symptoms in patients with ME. A few reminders about the call today. Everybody is on mute. We will be recording this webinar and it will be available on our YouTube channel. Because we're recording, when I finish this introduction, there will be a few seconds pause before we begin the webinar just to allow the technology to catch up with the recording. You can submit questions to us and you need to enter those in the box that you see on the right-hand side of your screen. And Professor Jason will address as many questions as time permits at the end of the webinar. And then just a quick reminder that the Solve ME CFS initiative does not provide medical advice. So today's webinar, as I mentioned, is appropriately and accurately assessing symptoms in patients with ME, and we're delighted to have Professor Leonard Jason with us today to talk through this topic. Although he can almost go without introduction, a little bit about our speaker. In addition to his professor position at DePaul University, he serves as the director of the Center of Community Research, which includes studies on pediatric epidemiology, prospective studies of college students with mono, and QEEG research. Professor Jason has been investigating ME CFS for nearly 30 years and has published a number of studies, including seminal papers on the epidemiology of the disease. He previously served as the Vice President of the International Association of CFS ME and as the Chairperson of the Research Subcommittee on the U.S. Chronic Fatigue Syndrome Advisory Committee. Professor Jason received his PhD from the University of Rochester in Rochester, New York. So welcome, Professor Jason, and please take it away.
Thank you. My webinar is titled Appropriately and Accurately Assessing Symptoms in Patients with ME. It's very important to differentiate fatigue from ME, or myalgic encephalomyelitis. Fatigue plus many somatic symptoms are very common among healthy individuals. Everyone, for example, feels fatigue at some point, and at any one time, fatigue is experienced by about 25% of the population. Yet most people recover from this type of fatigue. This general fatigue is very different from what patients with ME experience. Those with ME have symptoms very different from general fatigue, such as post-exertional malaise, PEM, and profound cognitive impairment. We also need to differentiate those with chronic fatigue versus ME, myalgic encephalomyelitis. About 5% of the population, or about 1 out of 20, experience 6 or more months of fatigue. That's what chronic fatigue means. There are multiple reasons for this chronic fatigue, including, for example, lifestyle issues such as overwork or even psychiatric issues like depression. Some CFS studies focus on this group that involves about 5% of the population who have 6 or more months of fatigue, the so-called Oxford criteria. Clearly, there's a need for instruments that can differentiate those with ME from those 5% with chronic fatigue due to lifestyle or psychiatric factors. Our task to accomplish is really to focus on number 2 below, but we're also going to briefly cover 1 and 3. One is we need to decide on which case definition to use for ME. This is objective criteria that operationalize the case definition. We need that to proceed forward. Number 2 is really the focus of this talk today. We need to ensure that clinicians and researchers elicit the same diagnostic information from an interview. This can be accomplished through structured interview schedules. Such questionnaires reduce differences in the way clinical information is elicited. And also, number 3, we need to develop rules regarding whether a symptom is severe enough to qualify as meeting criteria for a case definition. Now, recently, the CDC NIH Common Data Elements recommended that instruments should be used by investigators to study ME and CFS, and they stipulated what some of those could be. For example, fatigue and pain could be developed with good psychometric properties. For example, the PROMIS group. Those are very good instruments. However, instruments that capture core symptoms of patients with ME and CFS for example, post-exertional malaise, PEM, they might have different characteristics that involve things like onset and duration that are very different from other types of general scales. So we might need to really be very different in types of the questions that we have for some of the domains and symptoms of ME. Now we'll review 25-year effort to develop a patient symptom questionnaire so that you can sort of see how this process goes to try to start with something, learn from it, and then keep making it better over time so that we can ultimately assess symptoms in a more reliable and valid way. So really our efforts at DePaul University started in 1994. We had a 22 symptom instrument called the CFS Screening Questionnaire. It had excellent test-retest reliability, which we published, but this instrument only assessed the occurrence of symptoms, and which was what Fukuda, that case definition in 1994 indicated. But this first research effort helped our group realize we needed to assess symptom severity and not just symptom occurrence. Let me give you an example. This is 3 different groups on this particular figure: ME/CFS, MDD for major depressive disorder, and a healthy control group. If you're just looking at the percent that reports fatigue, there's actually no different from the depressed group and the ME/CFS group. They're both over 90%. However, if you talk about the severity and not just the occurrence, now you can discriminate the fatigue in depression and the fatigue in ME and CFS. So again, severity is very important, and that's what we learned from that particular first study in mid-1990s. So the next step was we developed a new CFS questionnaire that assessed frequency of symptoms, never, seldom, often, usually, always, and symptom severity for basically the intensity from 0 to 100. The items displayed adequate reliability once again, and by having this differentiation of severity, we were able to, with a sample of people with CFS and major depressive disorder, have 100% accuracy in discriminating the groups by symptoms that basically involve these 2 domains, both frequency and severity. Next, we developed a 20-item scale that basically was very interesting in that healthy controls, really there was just one large factor, so that wasn't really differentiated in terms of symptoms. But for those with ME and CFS, we actually got a 5-factor solution, indicating that there were differences between those who were patients and those who were controls on this particular instrument. So in 1999, we developed from all this experience our first instrument that we called the DePaul Symptom Questionnaire 1. That was to provide a structured approach to gathering standardized information to allow investigators to determine whether or not a patient meets diagnostic criteria. This was a 54-item scale. Each item measured frequency and severity. In addition to creating the instrument, it's critical to specify and operationalize thresholds, as I mentioned before earlier. Symptoms were counted if they occurred at least half the time at a moderate severity, and that was found to accurately distinguish patients with ME and CFS from controls. Let me kind of show you what the scale looks like in terms of frequency and severity. Frequency is none of the time, a little of the time 1, about half the time 2, most of the time 3, all of the time 4. Severity is 0 symptoms not present, 1 it's mild, 2 it's moderate, 3 is severe, 4 is very severe. Now, if we were just to kind of say a 1 or higher, that means a little of the time in frequency or mild in severity or more in severity, that would have important consequences for actually our work. Let me give you an example. These are some of the basically so-called Fukuda symptoms. And what you can see is that the light bluish bar are patients. And you can see that just about every one of the symptoms, they're up on 80, 90, or even 100%. And yet a healthy control group scored 1-1, which means mild and a little of the time, for 55% with fatigue, 65% on refreshing sleep. So that dark blue line are healthy controls. And you can see at a 1-1, you're actually bringing in lots of people who are healthy. In fact, about 34% of the controls would meet Fukuda symptom requirements if you basically reported frequency and severity of 1 or greater. Now take a look. If we basically change the criterion to 2 or greater, in other words, about half the time or most of the time or all of the time, or severity, moderate, severe, or very severe, look at the difference between these lines. You can basically see the lines that are light blue are the patients. The lines that are dark blue are the controls. And you can see much larger discriminations on each of these symptoms when you basically have a 2-2 criteria that helps separate these basically patients from controls. So the DSQ-1 has very good psychometric properties. Let me give some examples. A factor analysis resulted in a good factor solution with good internal consistency. We've published 2 articles on that so far. Also, good test-retest reliability among patients and controls. Also, we found that the 6-month time frame led to the most reliable reports of PEM and other CFS symptoms. There was also good agreement between physicians' assessments of whether a person had the Canadian consensus criteria of ME/CFS and the DePaul Symptom Questionnaire. The sensitivity was actually 98%, comparing a physician's diagnosis and the DSQ-1's assessment. This was an article by Strand and others. We also found that basically 5 PEM DSQ items were shown to select the widest net of patients, 97%. So actually those post-exertional malaise items were able to really capture most of the people who were patients. And it was higher than any other item or items from different scales designed to measure PEM. In addition, we've recently published a paper actually the last week that said, let's take 5 additional items, not those 4 core PEM items, but 5 additional items that measure PEM from the DePaul Symptom Questionnaire. For example, one of those items was whether symptoms continued for 24 more hours. Those types of items actually helped us get very good with specificity. So we could differentiate ME from chronic fatiguing illnesses such as multiple sclerosis and post-polio syndrome. Other findings, we've recently published a paper that looked at subtypes. So we used the DePaul Symptom Questionnaire 1, and we were able to get different groups of patients who had different characteristics of symptoms. So for example, those who had more gastrointestinal symptoms or orthostatic intolerance symptoms, or the combination, actually had the greatest functional impairment from all the different subtypes. We've also done some work with the DSQ-1 to document specific vision-related abnormalities among patients with CFS. Recently, we also published a paper on autonomic functioning. 7 of our DSQ-1 items measure autonomic functioning. For example, bladder problems, irritable bowel problems, nausea, feeling unsteady on the feet, like you might fall, shortness of breath or trouble catching your breath, dizziness or fainting, irregular heartbeats. They were significantly associated with low frequency heart rate variability, which is a measure of increased sympathetic activity. So again, the self-report measures were actually related to a very important biological instrument. In addition, QEEG has been performed for a functional connectivity analysis on 84 Brodmann areas, representing the entire cortex. And in this particular situation, we're using E-Loretta to estimate cortical sources. Well, we found, basically with the help of Mark Zinn and Marcy Zinn, that neurocognitive DSQ-1 factors were negatively associated with small worldness index for the delta band. And other investigators have found that this cortical slowing, which we found in the delta activity, is common in inflammatory disorders of the central nervous system. So you can see that our self-report questions are actually, again, very well represented and correlated and go along in association with some important biological measures. Now, we've recently looked at some cytokine findings with Dr. Ben Katz. We're currently collecting data on over 4,000 college students. We're storing plasma and serum samples in minus 80 degrees centigrade environment and pelleted cells in liquid nitrogen. Approximately 5% of our sample has developed mono, and we recently found that the DSQ1 domains of sleep, post-exertional malaise, neurocognitive, immune pain, and orthostatic intolerance were actually significantly correlated with these three important cytokine markers, again suggesting that self-report measures can be connected with important biological indices of this illness. Also, findings from other investigators not connected with our group, Murdock and others, basically in their article, said that traditionally utilized patient-oriented outcome measures are unable to identify clinically significant differences among patients being diagnosed or treated with ME/CFS. They went on to say the DePaul Symptom Questionnaire demonstrated excellent internal consistency, sensitivity, specificity, and a lack of ceiling effects. So after completing the DSQ1, an algorithm has been developed to determine if a patient meets any of the case definitions. For example, these 5: Fukuda's chronic fatigue syndrome, Carruthers CCC, Canadian consensus criteria, Goudsmit and others, London criteria for ME, the MEICC of Carruthers 2011, and the Institute of Medicine criteria. And in terms of access, it's freely available on REDCap. So if anybody here that's actually watching would like a free copy and would like to have a chance to use it, we also are publishing all our algorithms, all our abilities to kind of concretize different case definitions. So all that's available so that you can actually replicate the work we're doing with cutoff points and symptoms. In addition, this particular instrument is being used in Canada, Mexico, Iran, England, Norway, Spain, France, and Japan, and it has been employed in data collection efforts with Solve ME/CFS initiatives, Biobank, the CDC multi-site study, and the Chronic Fatigue Initiative. Now, recently, we've decided to develop a DSQ2, which is an expanded version. That includes not 54 items, but 78 items. So we included new PEM items based on Ramsey's work, and also because our original DSQ1 was developed just about the time the MEICC was being released, we wanted to include more MEICC items. And some of those items, as you can see, are ones below. So this particular instrument is longer, but it's also, we think, more accurate. For example, we got rid of some double-barreled items. Were split into 2 separate symptoms. So for example, one of our old items was losing or gaining weight without trying. So we broke that into 2, losing or gaining weight, as opposed to combining them. Here are some of the findings from our recent instrument. Using machine learning, the DSQ2 was able to differentiate those with ME versus MS with 5 symptoms. Just 5 symptoms, we could do a very good job of separating ME, myalgic encephalomyelitis, from MS, multiple sclerosis. Another article that we're currently working on, patients with ME have more severe symptoms than those with post-polio syndrome. That's with our DSQ2. And we also have a factor analysis. Helen Beedry is working on with Madison Sunquest, involving factor analysis using the DSQ2's expanded symptom list, which resulted in a really theoretically rich 8-factor solution, which we had never gotten before using the DSQ2. This particular instrument is also available for free at REDCaps. And again, not only is the instrument free, but the syntax is also available so that you can replicate any of the case definitions that we use or ones that you're interested in. Now, a number of people have said to us, okay, that's a 70 and a 50+ item questionnaire. How about something that's briefer? Because there might be a need for that. So we have recently, with Madison Sunquest, developed what's called the DSQ-SF, the short form. We've selected items from each of the domains identified in the Canadian consensus criteria. And let me give you an example. Of the 14 items, these are some examples. For post-exertional malaise, we have minimum exercise makes you physically tired. It's the sleep domain, unrefreshing sleep. the neurocognitive domain, problems remembering things, the autonomic domain, feeling unsteady on your feet like you might fall, neuroendocrine domain, cold limbs, and the immune domain, flu-like symptoms. And our DSQ-SF, using the Canadian consensus criteria, we had relatively similar number of patients who were identified with the DSQ-1 and the DSQ short form. And these initial findings suggest that the DSQ-SF serves as an effective brief symptom screen for use in time-limited research studies and clinical practice. This particular instrument, DSQ-SF, is also freely available on REDCap's shared library. We're happy to share it with anyone who'd like to use it. Finally, we have been working on pediatrics, which, as we all know, is a neglected area in ME and CFS research. We have developed a screening questionnaire that asks a parent or legal guardian about the health status of their children, ages 5 to 17. We have 18 ME and CFS related symptoms, and preliminary psychometric analyses displayed good internal reliability. And again, this particular screening device is available free at REDCaps. In addition, we have a parallel to the DSQ-1 for adults. We now have a DSQ-PED for pediatrics, and this assesses ME and CFS symptoms in children and adolescents. And again, based on the CCC case definition, Canadian consensus criteria, and this was basically, this case definition for pediatrics was endorsed by the International Association of Chronic Fatigue Syndrome. And we use a 3-month rather than a 6-month time frame for this instrument. The adults, we're looking for 6 months of symptoms. For children, it's 3 months. We also have some more child-friendly phrases. Rather than saying nausea, we say upset stomach. And we have 2 forms, one for the parent, one for the child. This allows for multiple reports on a child's symptoms. And we did compare 33 physician-referred youth with ME and CFS to 21 controls. And very interesting, 24% of the patients would be misdiagnosed using the Fukuda criteria, but with the pediatric ME-CFS criteria, only 3% would be misdiagnosed. So we do think that our instrument plus a case definition did a nice job. So the DSQ-P was also effective in distinguishing between those with severe versus moderate pediatric ME and CFS. Currently, we're using this particular screen as well as the more formal questionnaire on DSQ-PED in a large epidemiological study of pediatric ME and CFS that was started in 2014, continues today. We're very close to finishing collecting self-report data on over 10,000 youth in a random community sample, Chicago metropolitan area. We've already worked up over 200 medically and psychiatrically worked up, and we have a group that's screened positive for ME and controls. And we're also storing the blood, plasma, serum samples in -80 degrees centigrade environment in pelleted cells and liquid nitrogen. I might add that we are within a couple weeks going to be doing a large internet study so that we can compare our community-based study with one that's from data collected from people around the world. So we'll be basically putting that on the web very soon, and Madison Sunquest and some of our other RAs and project directors at our center are working on that. Just some preliminary data. This is a person who did her dissertation with some of our data sets. Orthostatic domain of the DSQ pediatric, for example, dizziness, chest pain, shortness of breath, feeling unsteady when standing, irregular heartbeat. Those are orthostatic domains. That was significantly correlated with a valid questionnaire for assessing autonomic symptoms, the autonomic symptom checklist. And this DSQ-PED is available from REDCaps in the parent version and the child version. And again, we recommend that we have directions as well as a scoring and how to use it for those that are interested. So now I'm going to sort of take a step back, and I know I've reviewed a lot of different ideas and lots of different studies, but now we're going to sort of talk about somewhat the bigger picture in terms of what's needed for the field of ME and CFS. The DSQ, DePaul Symptom Questionnaire, is an example of developing a standardized procedure for assessing ME and CFS symptoms. We need to ensure that clinicians and researchers elicit the same diagnostic information from an interview. That can really only be accomplished through the development of structured interview schedules. And these questionnaires reduce differences in the way clinical information is elicited. The DSQ, DePaul Symptom Questionnaire, is just one example of how we can do this. And there are other instruments out there. We're just focusing on the one that we've done our work on over the last couple years. I might add that we've recently developed another questionnaire called the DePaul PEM questionnaire. So that different questionnaires need to be developed. The DSQ is really a general measure of all the symptoms. This new questionnaire is really focusing on demographic and illness information, onset and triggers of PEM, consequence of exertion, symptom list, duration and recovery of PEM and pacing. So this instrument is really specific for people who have ME. And that's because really some of these symptoms are not occurring in other types of chronic illnesses. So sometimes we have to develop a questionnaire specifically for patients with this illness. And I might add that really the impetus for developing this questionnaire came from the patient community. And we had literally hundreds of patients who provided us information about how to develop this questionnaire in terms of the items, in terms of the areas to cover. So we appreciate very much the patient community, and we do think that there's incredibly important opportunities for us as researchers to work with the patient communities who really are the experts in this area and can really help us develop better instruments, not only the DePaul PEMQ, but also the other instruments we've been talking about today. So what are the next steps? In addition to using standardized questionnaires to reduce unreliability, and that's including the DePaul Symptom Questionnaire or the DePaul Post-Exertional Malaise Questionnaire, the two that we've just been talking about, we need to develop a consensus on rules regarding whether a symptom is severe enough to qualify as meeting criteria for a case definition. And again, earlier in this presentation, we talked about the importance of differentiating. Is it a 1-1, which means mild and a little, or are we talking about something that's a 2-2, which is moderate and at least half the time? So I think those types of rules need to be developed. Also, rules need to be developed in terms of, which of the subscales of a disability measure like the SF-36 do we use to basically indicate a person has a disability. So there's lots of rules that need to be developed. What subscale, what particular score, these are all critically important, and a consensus has to be developed to move the field along. So yes, we do need to measure things and we need to decide on what instruments to use, but just as important, we have to decide what the cutoffs are for those instruments. And in addition, some other things that need to be discussed and getting a consensus on and operationalized is something like, how do you measure substantial reduction in functioning? It sounds like a very easy topic, but I imagine if you have 5 people, you might get 5 slightly different answers if they're talking to a patient about whether they have and what type of reduction has occurred. How do you measure lifelong fatigue? Sounds like a simple construct, but the reality is it's not. What does it mean that fatigue is not substantially alleviated by rest? An item that's in most of the case definitions, but has it been operationalized? Needs to be. And fatigue that is a result of excessive exertion, that also needs to be operationalized with questions and cutoff points. And in addition, we need to think about what classification system best works with basically the large range of patients. So those with chronic fatigue of 6 or more months would be the broadest category. That would be similar to possibly the Oxford criteria. Those who meet an ME/CFS clinical criteria, for example, the Institute of Medicine 2015 criteria, which has few exclusionary illnesses, could be a clinical criteria, which is fewer people. And then a pure ME criteria could be based on the Canadian consensus criteria of 2003, for example, or the work of Ramsey 1988. And in an article we published a couple years ago, we talked about this three-part classification system. And this is what it looks like. In the general population, from 25 to 15% experience fatigue at any one time. So again, a very common symptom. Yet only about 8% have what's called prolonged fatigue. And that's basically of 1 or more months. And 5% have basically chronic fatigue, which is 6 or more months. So among those 5%, about 1 out of 20 people who have 6 or more months of fatigue, probably the largest group has, in a sense, we might call chronic fatigue or chronic fatigue syndrome. That's a large group that might be kind of the Oxford criteria, because that's what they primarily look at, is chronic fatigue. The Institute of Medicine might pick up 1% of the individuals because that's a clinical criteria, and they have very specific cutoffs that need to occur with that, which is a benefit of the IOM as a clinical criteria. But the group that has ME probably might be about 10% of the IOM group, 0.1. So these are the 3 groups. Each of them is worth studying, and it's important for us to make decisions as to how to designate those potentially 3 groups. Okay, as I conclude this talk, I think we need to just think about what needs to occur going forward. This is my recommendation. We need to develop a consensus on what research case definition to use. The consequences of failing to reach a consensus on a research case definition includes replicating findings at different laboratories, estimating prevalence, difficulties identifying biomarkers, and difficulties determining effective treatments. So yes, we do need to have measures selected. We do need to have questionnaires that have clearly some reliability and validity to use. We need to have cutoff points specified as to how to use those instruments so that we can have laboratories in different places in common agreement. But ultimately, we also need for people to recognize it's like a stack of cards, playing cards. That foundation is whether a person has or doesn't have a particular illness, and that has to do with the case definition. Key gatekeepers, including scientists, patients, and government groups, need to be actively involved in what I think is an open, transparent, inclusive, and international effort to accomplish this. Thank you very much for this presentation. I've tried to leave about 10 or 15 minutes for questions, and at this point, I'm very happy to try to answer some of your questions.
Thank you so much, Professor Jason. And hi, everybody. This is Alison Ray Miller, and I'm part of the research team working alongside Dr. Sadie Whitaker, our Chief Scientific Officer. And I just want to thank you again so much, Professor Jason, for giving such a comprehensive overview of your decades-long work to establish questionnaires and dig into the epidemiology of this disease. And it was such a great presentation, particularly as it's happening when you're about to release some new publications. And so it seems very timely. And so we got a few questions to come through from a really attentive audience. The first of these, I know in your presentation you spoke a bit about the need to use not only frequency, but also severity as a component of analyses. And so one individual had the question about whether or not the DSQ has been tested on patients with very mild ME, and if so, how accurate was it?
So that's a great question. Yes, we have used this questionnaire with people of all different gradations of ME. We've used it with those 25% of patients that are homebound. We've used it with patients who are able to work full time. So yes, we have a very large spectrum. The DSQ has been used. Our database that we have databases here that have over 1,500 people in them. So yes, and we have a number of different databases. But let me go back to frequency and severity and just help understand why that's so important. So think about it. A symptom could be something that is very infrequent. For example, you might have maybe migraines once every 2 months for maybe a couple hours. So it might be very severe when you have it, but the frequency is something that is it really only happens a little of the time. So that particular symptom, you probably don't want to count because it happens so infrequently. On the other hand, you might have a symptom that is frequently occurring, like for example, half the time. And yet the severity is so mild in terms of, for example, a pain that you might have that's so mild that it probably doesn't reach the criterion of basically something that you really want to count as a symptom. So if you just look at frequency, you're going to miss some of those severity issues that help define it. If you just look at severity, you're going to miss some of the frequency issues. So it's only by having these two domains that you can do things, for example, like differentiate the depression of major depressive disorder from those who have ME. And clearly, frequency or occurrence doesn't do it because both of them experience this type of fatigue, for example. But if you basically look at severity, that's when you're able to differentiate those with major depressive disorder from those with ME, as I showed in an earlier slide.
Great, thank you so much, Professor Jason. And just to springboard a bit about what you just mentioned, distinguishing major depressive disorder using severity, we had another individual just comment about their observation that often when folks they've spoken to say they've recovered from ME/CFS, they still think that they have had depression. So can you just speak a bit more about our ability to distinguish between the, ME/CFS with co-occurrent depression and a major depressive disorder?
Yes, that's again an excellent question and something that I think has led to all types of confusion. The reality is major depressive disorder is one of the most common psychiatric disorders. The only thing that's more prevalent is alcohol and substance use disorders, which affects about 9.5% of the population. But actually, a major depressive disorder affects around 2.5% of the population. So very common. So lots of people who are depressed have some of the symptoms of basically ME and CFS. So for example, they often have loss of energy. They often have fatigue. They often have some muscle pains. They often have some sleep difficulties. They also have some cognitive impairment. So it's possible that lots of people go to primary care with some of these general symptoms who have solely an affective disorder, and those individuals could mistakenly be diagnosed with ME. And if that happens and they're put into clinical trials, those people who have, in a sense, more of a psychosocial, psychogenic, for example, depressed reason for their symptoms, they're going to respond very well to lots of interventions like cognitive behavior therapy or graded exercise. So it's very important to recognize that we need to be very careful in the selection of individuals who are appropriate for either clinical trials or for individuals who we have in a patient group that we're trying to understand biological markers. Now, here's the key thing that we found over 15 years ago, one of our early studies, is that if you really ask the right questions, for example, severity, you're able to begin to differentiate these conditions. And let me give you really the best way of thinking about the difference. If you ask a person who has a major depressive disorder, what would they do tomorrow if they basically got well? They'd probably say, we're not sure. If you ask a person with ME and CFS, what would they do tomorrow if they were well? They'd probably give you a whole list of things they want to get back to. So very different. They don't have basically the self-reproach. ME people do not have the self-reproach. The people with depression, major depressive disorder, do have self-reproach. Also activity. This is why cognitive behavior therapy works so well for those who are depressed. Activity makes people with major depressive disorder feel better and actually improve. As a matter of fact, activity is just about as effective as a lot of medications for those with major depressive disorder. So if you push a person and get them involved in an activity program, they're going to do great. If you basically do the same with an ME/CFS group, you're going to probably end up with relapses because post-exertional malaise is one of the primary symptoms. So yes, it is important to differentiate these conditions, but also we need to recognize, which your question really started with, is that there's some people who have a major problem with life, in that, in a sense, they can't work anymore. Their social life has been changed. Their responsibilities at home have been changed. They can't clean, they can't shop. They have all these limitations, and those people are probably more likely, as with any chronic medical condition, to have some depression because you've got a loss. You have multiple losses. So the fact that you have some individuals who have ME/CFS with depression is not it's to be understood, because you have all these losses you have to deal with. However, it's not the same as a solely major depressive disorder. That distinction is so incredibly important, and that's why diagnostics and that's why case definition matters, and exclusionary criteria matters. And if you don't get it right, you have the types of outcomes that have occurred in the ME and CFS world.
Thank you so much, Professor Jason. It was a really great overview. And we have another question in which someone wants to know a bit more about quantitative EEG abnormalities that your group has done some work in, and whether or not those would show up also in EEG or sleep studies that patients might have had done in non-ME clinics.
Yes, so I just want to kind of call out the work of Marcy Zinn and Mark Zinn. They have made incredible contributions to the quantitative EEG literature. And I've been very fortunate to be associated with them for the last few years at my Center for Community Research. And yes, they have actually used procedures which involve EEG. But you know, here's the thing. If you go to a neurologist and you look at EEGs and you get two people to try to agree on it, the reliability is very low, unless you have someone who has very spiking with epilepsy. So it's not easy to read EEGs. So you really need to take that information and put it into a computer with mathematical algorithms to actually make sense out of it. And we're able to do that with some great work that's been done with E. Loretta. And what they have found in a variety of studies, and these studies actually began at Stanford with Dr. Montoya and have continued at DePaul. And these studies have looked at, for example, delta. And delta is something that should occur when you're sleeping, okay? Delta waves. But what happens in our findings, some of the initial findings, is that actually what you find is that during the day, these individuals with ME and CFS are in delta wave, which means they're sleeping, or their sleep is kind of part of the cognitive disorientation and impairment that's occurred. And yet things like beta are not occurring. So yes, we really see something that's diagnostic, but what's really most exciting is the pilot work we're currently doing. And again, just to call out to the Zinns, because we've actually begun to develop a challenge where we do hand grip, and we can actually, in a very short 3-minute exercise, show that the impairments that occur are very profound, these brain waves, and they're maintained a day later. Whereas with controls, we don't see that. So this is a paper that is being written up by the Zinns, and we're really excited to basically show how an exercise challenge can affect the brain waves. And of course, as you recognize, some of our self-report questionnaires, we also use the DSQ, so we can relate self-report measures to biological measures. So we're not saying you should just use one or the other. We're saying there's no reason you can't use both, because you can actually enrich your studies by looking at the more biological and the psychological self-report measures, bring them together, and then you have a more comprehensive picture of the types of symptoms that seem to persist over time, for example, with post-exertional malaise.
That's great. Thank you so much, Professor Jason. That does make sense that cross-referencing some of those data points might produce something more powerful. And I think we'll just have time for 2 more questions. So my first one from an attendee is, you mentioned that you were conducting a pediatric epidemiology study that will include some self-report data and a medical workup in addition to biosample storage. And so an attendee wanted to know whether these samples, might be made available to other studies or researchers, for example, some of the work done by Ron Davis at Stanford or other research groups. And just to tack onto that, how can we just increase collaboration more generally within this field? That's something that Sadie in our organization is really, really passionate about, is to how get more researchers to talk to each other, to share findings, and to strengthen the research generally. And so if you could address those 2. Thank you.
Yeah, I think that, collaborations in the field are occurring at such a rate that when I started doing work in the early 1990s to today, it's just a different scenario, and that's exciting. Matter of fact, just to mention, we had last week an investigator from Spain and one from Mexico visiting our group. And we have, as you know, Spanish versions of our questionnaires. And actually our Jesus, it has a sample of about 100 pediatric cases that he's going to be using our questionnaire with very soon. And we're talking about, and we're actually using their data set that was collected in Spain, and we're analyzing it now and looking at how it's different from kind of a US sample. And we're also thinking about ways of generating samples from other countries in South America and Latin America. So yes, I think Norma Coffin, who is our collaborator from University of Mexico in Mexico City, we've been collaborating with for a number of years. So we think that collaboration is critical. We think that sharing data is critical, but we also think it's important to have a common language so that, in a sense, you have instruments that can be compared. I think sometimes when you put 2 instruments together that are from completely different groups, you might have some difficulties because the time frames might be different, the anchor points might be different, and the types of symptoms being assessed might be slightly different. So I think it's important that's why I really made 2, the area of common instruments, so important, so that you have data that you can compare across groups. And to the extent that you can do that, that really furthers the collaborative process.
That's great. Thanks for the overview on some of what you're currently involved in. Those all sound really exciting, and there's so much in line with what I know a lot of people want to see as far as collaboratively moving the field forward. And what you started to touch on at the end of your answer there about reaching a consensus point, and some of what you spoke about in the last few slides about next steps. We got a great question from one of our attendees, really a key question, which is, what should be the process for choosing a research case definition? And I think we'd all be interested in your overall view on coming to a consensus on a case definition and having it be useful clinically and useful in research.
Yeah, so the key thing here is that there are several possible ones that are out there. Certainly Ramsey has some great ideas with other people from Great Britain who have contributed to that discussion, and certainly in Canada, Byron Hyde's work. And there's some great people, the Crothers work in 2003 and 2011, and others who have, come up with some interesting case definitions. And really, our group at DePaul has really just tried to take those case definitions and operationalize them. We have preferred in some ways a more empirical approach, which is to kind of let the data speak for itself. with some of our data mining and factor analytic studies that we've done. And we've come up with a more empirical method that can identify what are the critical symptoms for a case definition. But it really doesn't matter. You've got at least a nice array of possibilities. The key thing is there needs to be an international effort to bring together scientists, to bring together patients, and to bring together government bodies. If you leave one of these groups out, you're not going to have a consensus, and you're going to have a major constituent group upset. And the reality is, if you don't get the buy-in at the earliest time point in a process that's iterative, that's basically giving feedback back and forth, if you don't start the process out right, you have all types of difficulties you will encounter. So I think it's got to be transparent, it's got to be open, it's got to be collaborative. And I think if you can develop structures that allow that to happen, you have the possibilities of, I think, revolutionizing our field. And I think not to do this represents an enormous challenge to researchers. Because think of it, how many researchers even want to come into an area when they basically say, how do you identify patients? How do you identify who this is? And if you can't tell them a systematic way of doing that, why do they even want to come into this area and try to compete for funds if the very diagnostic challenge is such a problem? So you need to solve this issue for not just the scientific community to get people interested in being part of this, but ultimately for the patient community who will benefit from the research and the services that emanate once a good case definition is agreed upon.
Thank you, Professor Jason. This is Sadie again, and I couldn't agree more with everything that you just said. So thank you for that answer, and thank you again for a very, very interesting presentation. I know that I've learned a lot, and I find it absolutely fascinating, and I find your work to be very compelling. I'm sure many people who've listened in today feel the same. So thanks again. Just wanted to, if you look at the slide that's up at the moment, just wanted to remind you that we do have some future webinars. They're available at the link that's listed on the slide. We also send out newsletters where you can stay informed on the latest updates. We are in the process of relaunching our biobank and registry, and I'm sure we'll be providing more information on that very shortly. And lastly, obviously, we rely on donations to drive research and fund progress for this disease. So please feel free to click on the donate link and donate to our organization to help fund that research. So with that, I'd like to wish everybody a good day, and thanks again for joining. Bye.